Chapter 32 is going to cover care of the critically ill patients with respiratory problems, and this is outcomes 53 through 59. So this is the last page of your outcomes. So pulmonary embolus then is going to be the first thing we talk about. Usually when we talk about pulmonary embolus, we think about deep vein thrombosis and the clot breaking off and traveling to the lungs. And yes, that is true. That's probably one of the most common things that we see. So obviously we take great measures to prevent DVTs. But honestly, if you look at page 604, there are so many things that can cause a PE. Fat, like if you break a bone and the fat from the bone gets into the bloodstream. Oil, air, tumor cells, amniotic fluid, fetal debris, foreign objects like the tip of an IV catheter, injected particles, like if you mix together two meds and they start to precipitate in the syringe, infected clots, all of those things can cause a PE. So it's not just a DVT. And then pelvic surgery also should be on there, because somebody who's had pelvic surgery can get blood clots in the pelvic saddle, and those can break loose and travel up to the lungs as well. Risk factors include immobility, central venous catheters, surgery, obesity, age, anything that increases blood clotting, any history of blood clots, smoking, pregnancy, especially smoking when combined with oral contraceptives or any sort of hormone replacement, a history of heart failure, stroke, cancer, especially if it's lung or prostate, trauma, and then things like, AFib and things like that that increase the risk of forming or throwing clots. So anything that causes venous stasis increases the risk of clots. So what does it look like on 604? On 605, there's key features for respiratory, cardiac, and then low-grade fever, petechiae, fluidic symptoms. And on 604, there's a great chart 32-1 that talks about prevention of pulmonary emboli. And you notice that most of those are related towards preventing DVT, since most PEs are caused by DVTs. Most patients will develop hypoxia that can be seen on SpO2, but not all patients will have a decreased O2 set. So pulse oximetry is valuable for establishing a baseline and watching trends, but not diagnosing a PE. A D-dimer is helpful, but remember that it could rule out a blood clot by being negative, but it can't rule in a blood clot by being positive, because it just says that the body's breaking down fibrin somewhere in the body, that clot, but it's not specific to a DVT or a PE. You can do an ultrasound of the lower extremities to look for a DVT, but again, that just says that the person might have a DVT. It doesn't necessarily say that they definitely have a PE. Instead, the best test, the gold standard, is a CAT scan or CT angiography of the chest, where we inject the dye. Typically, we like to have a 20 or an 18 gauge IV in the AC, or at least close to the AC for these studies, because the dye has to reach the lungs fairly rapidly, so it needs to be a good sized vein. And if the person is allergic to CAT scan dye, then we do the VQ scan, which we talked about as well. ABGs themselves in a patient with a PE can be very confusing. So at least 40% of patients with PEs present with some form of chest pain. And in addition, many of them have hypoxia. And so the hypoxemia, the hypoxia, the chest pain cause a sensation of anxiety. And for many, it causes this restlessness and impending doom that your book talks about. So one of the first things that we see So early on, I'm going to do like primary ABG. Initial ABG is an increase in the respiratory rate causes an increase in the pH, right? Because I'm blowing off hydrogen, or I'm blowing off CO2 really. So I'm increasing my pH and I'm driving down my CO2. So initially, I'm actually going to develop a respiratory alkalosis. And I know that seems almost counterintuitive, but that's just in the very early phases. Then what's going to happen is in response to the hypoxia, the body's going to start shunting blood, and the ratio of arterial oxygen and inspired oxygen starts to fall, and blood is shunted from the right side to the left without picking up any oxygen from the lungs. So now the CO2 levels rise, and I'm not exchanging gases as well. And depending on the size of the PE, this may happen very quickly or very slowly. You can actually have lots of PEs at once. So secondly, my pH will drop and my CO2 will rise. So my initial blood gas, like if I hit it right at the onset of this, I'll see respiratory alkalosis. And then my second blood gas, I would see respiratory acidosis. And then, because the body systemically is hypoxic, all of my peripheral tissues are also going to kick into that anaerobic metabolism. And I'm going to have not only a decreased pH, but I'm also going to have my increased CO2, and I'm going to have a metabolic acidosis, so I'm going to have a decreased bicarb. Right, because the body's spitting out all this lactic acid, and the bicarb's trying to buffer it. So as the bicarb's trying to buffer the lactic acid, there's fewer bicarb floating around in the bloodstream. So I'm going to have then both a metabolic and a respiratory acidosis. And that's going to cause a fairly profound drop in the pH once that occurs. So this can be very life-threatening. Management of a patient with a PE depends on the extent of the PE. On page 606, 607, and 608, and even 609, there's some great charts on there. Make sure you review those. So it talks about care of the patient with a PE, the PE severity and management options, drug therapy that we use, and then some patient-centered care and prevention of injury for the patient receiving anticoagulants, fibrinolytics, and antiplatelet therapy. So all very good to review. So just some basic things, right? Oxygen to maintain a stat, so titrate to effect, continuous patient monitoring, so cardiac monitoring, O2 set monitoring, end-tidal CO2 monitoring, blood pressure monitoring, monitoring your INOs. Like, just be a really good, diligent nurse and monitor what you're putting in, what you're taking out, and what you're taking away from that patient. Adequate venous access, because if you need meds in a hurry, it's not okay to say like, oh, his IV site clotted off before. Drug therapy, right? So we can give anticoagulants to prevent further clot formation, and then fibrinolytics to break up the clot if it is a massive PE. So the risk-benefit ratio of fibrinolytics is not strong enough in low-risk PEs, so we don't use them. Treatment, the therapy is kind of debated in the submassive PE about whether or not we're going to use them, because the risk for bleeding is so high. So if they start to decompensate or look like they're getting worse, then we would use them. And then for a massive PE, because the mortality rate is like 65% or greater, we use them because the mortality rate from the PE is actually higher than the mortality rate from the side effects of the fibrinolytics, so the clot-busting drugs. Once you give those clot-busting drugs, some really important things to keep in mind, okay? You should assess the patient for evidence of bleeding. So oozing, bruises, especially bruises that cluster, petechiae, purpura, every 2 hours. You're going to look at everything that comes out of that body, stool, urine, any drainage, any vomit, for blood. So any gross blood, anything you can see with your eyes, and then you're going to test for occult blood as well. So you're going to test stool and urine and emesis and anything else to see whether or not there's hidden blood in it. You're going to measure the abdominal girth at the level of the umbilicus every 8 hours, so at least every shift. If you're working at 12, it's going to happen twice in your shift. And the reason for that is because if there's internal bleeding, the abdomen is going to increase. And certainly between the 8 hours, if you start to notice a rigid abdomen or, ecchymosis on the flank or retroperitoneal area, then obviously they have something going on, right? You're going to monitor those lab values daily. Look at the CBC, and you're going to look at like the PT, PTT, INR. So you're going to look at the coags. And just see, sometimes patients after they get lytics, they need a transfusion. So we're just going to keep an eye on that. And then surgical management. So the other option is if we can't use the clot busting drugs, sometimes we can go in and we can actually take it out. So just like a cath lab for the heart, they can go in and do an embolectomy. So surgically or percutaneously, so through the skin, removing the clot. So if fibrinolytic therapy is contraindicated, or if they have massive or multiple large pulmonary emboli with shock or bleeding complications, then we would go in and surgically remove the clot. And then we talked about the IVC filters, or the green-filled filters that look like little umbrellas. They usually stick them in through the femoral site, and they go up into the inferior vena cava, kind of pop open and sit there. They catch the clots from the lower extremities as they come up, and then the body just breaks them back down. So the D-dimer would always be elevated in somebody who had chronic clotting and coagulation issues with an IVC. Okay, so that's kind of management of our PE. One last thing I should mention about PE, and I thought it was on the next slide, but it's not there, is that if you have a patient who's going home with a PE, and this happens to us frequently, they're going to go home on like Lovenox, and also probably like on Coumadin, but you're going to need to do teaching on Lovenox, okay? So on page 610, Chart 32-7, Patient and Family Education, Preparing Self-Management for Preventing Injury and Bleeding. Read through that. That would be important information as well. So acute respiratory failure is when there is inadequate gas exchange, either because of blood flow perfusion issue or because of some sort of lung issue. But basically on a blood gas, the O2 is less than 60, okay? The CO2 is greater than 50, and the pH is less than 7.3. So they look like they have a severe respiratory acidosis with hypoxia. So that, by definition, would be acute respiratory failure. pH of less than 7.3, PaCO2 of greater than 50, and a PaO2 of less than 60. And a PaO2 of less than 60 translates to an SpO2, so a finger probe, of less than 90. Okay, the patient is hypoxemic, and that translates then to tissue hypoxia as well. And this is a huge problem, right? Because that's going to lead to anaerobic respiration and metabolic acidosis as well. So there's a ton of extrapulmonary and intrapulmonary causes of ventilatory failure, but basically with a ventilatory failure, the blood flow is okay, the air movement is not. So there's either a central nervous system problem, a chest wall problem, a foreign body airway obstruction, some sort of degenerative muscle condition where the diaphragm isn't working, you fracture your neck and cut your C-spine, and the diaphragm and the respiratory muscles are paralyzed. There's so many things that can cause it. So you can look at table 32-2 on page 611, but it is a problem with ventilation, so you're not moving air in and out. In an oxygenation failure, the patient is ventilating, but for some reason there isn't either enough oxygen, or the oxygen can't make it across, or it can't bind to the hemoglobin. So this could be a problem with perfusion within the alveolar blood system. It could be a problem with like a PE, or it could be, you know, that you're in an environment where there's no O2, or that there's something wrong with your hemoglobin. Okay, so air is going in and out, sorry, but gases are not making it across, right? So oxygenation is the exchange of gases, or respiration, whatever you want to call it, but ventilation is the movement of air in and out. And then we really have a problem when you have a combined ventilatory oxygenation failure. So when we have a problem with both respiration and ventilation, where you can't get enough air in and out, and you can't exchange gases easily. So these are our patients with our chronic airflow limitation, which we talked about in a prior chapter, asthma, emphysema, chronic bronchitis. So the diseased lung itself causes problems with ventilation and air movement, and thickening or collapsing of the alveoli causes a problem with gas exchange. So the person has increased work of breathing, but the respiratory muscles don't function effectively, and they just can't pull air in and out. So these people fatigue fairly quickly, and oftentimes, this can turn into then cardiac failure and cardiopulmonary arrest. If you come across somebody who's in severe respiratory distress, we try to fix the problem. When they go into respiratory failure, we take over. So oxygen therapy then would be probably through a bag valve mask or an ET tube, position of comfort, relaxation, diversion, guided imagery, if they are short of breath and in respiratory distress or increased work of breathing. If they're in respiratory failure, they're going to end up on a vent. And then energy conserving measures. So remember that somebody who has severe shortness of breath, we don't want to get them out of bed and walk them down to the dining hall. They probably need to be fed in their room. They should have a commode at the bedside or be using a bedpan. We should be giving them their medication, like their nebulizers or their puffers, a half an hour before meals or activity. We should cluster care. Just all those general concepts, keep those in mind. And then medication, right? So definitely our beta-2 agonists, probably our anticholinergics, and then steroids as well could be used to help dilate the airways and open things up. Just the same drugs that we use for other things. If somebody is having a very, very severe asthma attack and we can't break it with our other meds, one of the meds I didn't mention that we do use is mag sulfate. So we use mag through the IV, And the reason that we do this is it is a smooth muscle relaxer, and it actually relaxes the bronchi, and it can break a severe asthma attack. So for somebody who's in respiratory, either very, very severe respiratory distress or respiratory failure from an asthma attack, and we're just not able to turn them around, sometimes we can use mag sulfate on them, and that will help turn them around. Heliox, oxygen therapy, mechanical ventilation, all of those also might help. The patient with acute respiratory distress syndrome is experiencing respiratory failure with hypoxia that persists despite oxygenation, and that's pretty much the hallmark sign of this. So somebody presents with respiratory distress and then respiratory failure, and we're giving them a high concentration, high flow, even positive pressure ventilation, and they're still not exchanging gases. They still have hypoxemia and hypoxia. They have decreased pulmonary compliance, so they lost the elasticity in the lungs. They're short of breath. They have non-cardiac associated bilateral pulmonary edema. And then we know that because we can do wedge pressures. We can do a catheter right into the pulmonary artery and test the pressures, and the pressures are low. And pulmonary causes of pulmonary edema would show pulmonary hypertension. Or sorry, cardiac causes of pulmonary edema would be hypertension. And then on x-ray, the person has this ground glass appearance of dense pulmonary infiltrates. So there's a lot of things that cause ARDS. So any acute lung injury can cause it: sepsis, burns, pancreatitis, trauma, transfusion. We see it a lot in drug overdoses, PE, aspiration, inhalation injuries, like somebody who was in a fire or who inhaled superheated gases. And basically, no matter the cause, it causes the same thing, where it basically it damages the lungs, where it's almost like a preemie baby, where they don't have any surfactant, and they can't keep the alveoli open, so the alveoli just collapse and they can't exchange gases anymore. So even though you're super oxygenating them, none of the oxygen is making it across. I put a article on Moodle, and then I also put a copy of it on the coffee table that talked about ARDS and best practices currently in nursing. And go ahead and read that, because it's really fascinating. It was really well written. So the diagnosis of ARDS is established by blood gas, and basically even with high concentration oxygen, the PaO2 is decreased, and they need intubation and mechanical ventilation, and then that chest x-ray that I talked about. So that ground glass appearance on the chest x-ray. For interventions, positive pressure ventilation, again, usually intubation. Sometimes they'll try to manage it with CPAP, but the settings are different with the ARDS patient than with a regular patient. We try to be low with our tidal volumes because the lungs have lost their elasticity, and we try to be gentle with our PEEP. So the positive end expiratory pressure, we try to keep that fairly low as well, so that the alveoli stay open, but that there's not excessive pressure in there, because we don't want to do any damage. It's the lung tissue is very, very fragile in these patients, and it's very easy to do extra damage. In order to get best lung compliance and to decrease the oxygen needs of the entire body, we often sedate and paralyze them for the extent of their treatment. And they talk about positioning in the book, which is interesting. These patients actually often do well in a prone position, and so there's special beds that will put them in a prone position, kind of cradle the head and face, and allow the intubated patient to be prone, so that's face down. And as you can imagine, all of your assessment changes when the patient is face down. All of your care changes when the patient is face down. But they also say manually turning the patient every 2 hours has been shown to improve perfusion. But you have to be really diligent about that. There's also ECMO, which is the extracorporeal membrane oxygenation, which is like the heart-lung bypass equipment. So if somebody really can't recover the lung tissue, if they absolutely can't exchange gases, we can bypass the heart and lungs and basically put on, you know, a fake lung similar to like the kidney in dialysis. This is the lung, the ECMO lung, and it will, you know, exchange gases with the environment. So it kind of scrubs the blood a little bit clean with the gases and then puts oxygen on. So, and they can adjust the exact concentrations, which is kind of cool. And then that gives the lungs some time to relax and recover. And then interestingly, if there's an infection, we treat it with antibiotics, but nothing else really seems to work. We're doing some experimental stuff right now. But research shows that patients actually do better with more conservative fluid rather than high levels of fluid. And so there's some discussion about, you know, third spacing and are they developing like pulmonary edema and third spacing from excessive levels of IV fluid while they're in the ICU, and that's kind of washing out the surfactant. So it'll be interesting to see what the research shows on ARDS down the line. Just know that this is often fatal. It can happen, you know, very, very quickly. So if you have somebody that you think is at risk for this, you want to monitor them very closely. On 614, it starts talking about the patient that requires intubation and ventilation and nursing care. So depending on the facility that you work at, some ET tubes are taped. The current recommendation is that if it's available, you use a commercial device to hold it. So there are commercial tube holders on the market, like the Thomas tube holder, things like that, that actually kind of clamp down on the ET tube and hold it at the correct depth at the mouth. There's so many of them out there. There's different ones that you'll see at almost every single facility based on ease of use, cost of the product. You know, if you get one that you really like, you know, people usually stick with that one. So securing the tube is really important. So you want to make sure that you have it at the right depth. And you want to check it frequently to make sure that it hasn't gone up or down, hasn't migrated at all. Mouth care, also we talked about, that helps prevent the VAPs, the pneumonias. So you want to do diligent mouth care like every hour. And on page 617, there's chart 32-9, care of the patient receiving mechanical ventilation. So there's a lot of great information on there as well. Frequent turning at least every 2 hours is important as well. Only suction when needed. If you think that there's something wrong with the tube, the mnemonic that we use to check the tube is called DOPE. So first we check to see if it's displaced, so has it come out? Then we check to see if it's obstructed. Can you ventilate or suction through it? Then we check for pneumothorax. Do they have bilateral breath sounds and chest rise? And then equipment failure. And that's equipment failure is really the first thing that we check for, because we take them off of the mechanical ventilator and we ventilate them with a bag valve mask. So yeah, the ventilator technically could fail. As far as mechanical ventilation goes, it basically takes over for the person who has to stand there and bag the patient. There's a lot of different settings that we can use. We set the volume, we set the rate, and we set the amount of pressure that the person has to exhale against. Most of the vents can also be used as a CPAP or BiPAP as well, which is kind of cool. And the vents can be set to assist the patient with their own breathing, so it only triggers the pressure when the patient starts to draw a breath, or the vent can be set to deliver a set rate regardless of what the is breathing. So the vent settings are, I don't want to spend a lot of time on that, but vent settings can be very complicated. Respiratory does a fabulous job. You do want to document vent settings in your notes, or if you have like a drop-down box, you want to document the vent settings for your patient, so that if something changes or whatever, something fails, you always have a reference to look back to quickly and see whether or not the person's there. So you want to monitor somebody who is being ventilated for pain, because even if the person is paralyzed, they still can experience pain. So things like tearing of the eyes, chewing or licking, or mouth movement around the tube, and then tachycardia are all signs of pain, and you want to treat the patient. So you want to give them either pain medication or sedation or something like that, so that they're not paralyzed and suffering, because it's very scary, and it's also very uncomfortable to have that tube down your throat. You cannot talk, obviously, while you have that tube through your vocal cords. So if the patient is awake and sitting up and we're working towards weaning them off the vent or extubation, you're going to need to give them like a dry erase board or something like that to write on, or pen and paper, in order to communicate with them. And as I said, we only suction when needed, right? So if there's like a lot of secretions, if it's like really rattly, if the vent is alarming high pressure, that could be from the patient coughing, showing that they need like more paralytics or sedatives, or it could be that there's like a mucus plug or something, or if you listen to the breath sounds and there's like a lot of rhonchi, or if they have decreased breath sounds, all of those would be an indication to suction. Suctioning through the vent through an ET tube is no different than other suctioning. The same general principles apply. So there's some things that can happen, complications from the vent. Remember I said that your chest only has room for like blood or air, not both. And so what can happen is that if the vent settings are wrong, like there's too much pressure, too much volume, it can actually impair cardiac output. So you can have hypotension and cardiac shock, essentially, from too high pressures from the vent or too high volumes. The person can actually also trigger stimulation of the vagus nerve by fighting the vent and trying to like hold their breath or work against the vent. So that's a problem, and then that can actually cause barotrauma, volume trauma, atelectasis trauma. It can cause a rupture of any different part, and you can end up with a pneumothorax as well, and then that ventilator-associated lung injury. So you want to assess lung sounds, you want to assess O2 sat, end-tidal CO2, check for subcutaneous emphysema. Always be doing a really good respiratory assessment on these patients because they're critically ill. So the next section talks about chest trauma. Pulmonary contusions occur usually with blunt force trauma to the chest. They cause bruising to the lung parenchyma, and then cause a problem with gas exchange, so they can lead to oxygenation issues. Rib fractures are usually, again, from blunt trauma to the chest. And the problem with rib fractures, besides the fact that they're incredibly painful, is that people tend to splint that area, so there's a problem with ventilation and oxygenation. And in addition, if the ribs are displaced, they can lacerate any of the blood vessels or the internal structures like the liver, the spleen, the lungs, or any of the different vessels that are in there, even the kidneys. So we worry about rib fractures. Flail chest, we're going to talk about in a second. Pneumothorax, tension pneumothorax, we're going to talk about in a second. And then tracheobronchial trauma, you can actually have like a complete disruption of the tracheobronchial tree from a rapid deceleration injury. Probably the worst type of chest or abdominal trauma you can have is deceleration injury, where you stop suddenly. So if you're ejected from a vehicle, if you're skiing or snowboarding and run into a tree, if you're on a motorcycle and you hit like a stationary object, or you T-bone a car, when you yourself are moving quickly and you run head on into something else, your body stops, but your organs swing forward. And when your organs swing forward, your liver tends to dissect itself, your aorta tends to shear, and then you can also have rupture of the tracheobronchial tree. So deceleration injuries tend to be absolutely terrible. Your book gives you an example of somebody who probably was not restrained, but strikes the neck against the dashboard or steering wheel during a car crash. And then you end up with either a pneumomediastinum or a hemomediastinum, where you have free air or free blood within the mediastinal cavity, which is absolutely devastating and very difficult to correct. So if you think about that, you're only supposed to have a heart in there, and now all of a sudden you have like blood or air putting pressure around your heart. And obviously you would get sick and collapse very quickly. Flail chest is where you have 2 or more ribs broken in 2 or more places, and your book does a good job of saying neighboring ribs. So basically you have a segment of chest wall. So you see here you have a segment of chest wall where the ribs are broken out almost like a raft. And you have paradoxical movement. So normally on inspiration, the chest wall expands and raises, and on exhalation, the chest wall deflates and lowers. And what happens with a flail chest is that on inspiration, the chest wall expands and raises, except that the vacuum that's created inside sucks in that little raft component of ribs that's been broken free. So it sucks in while the rest of the ribs are moving out. And then when you exhale and the rest of the ribs are coming back down, the positive pressure inside the chest forces that little flail segment out. And so you can not only see it popping in, out, in, out, in, out, you can actually feel it crunch, 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 crunch as it's going in and out. The person obviously is in terrible pain. They're really not happy about that. You can also get a flail sternum from striking the steering wheel, where you separate the sternum from all of the ribs, and while you're breathing in and out, the sternum is popping in and out as well. Incredibly painful. It should just, usually we kind of put the patient on mechanical ventilation, and that stabilizes that flail segment because there's no internal pressure changes. And then, they can surgically stabilize it if needed, but otherwise it's, IV pain medication, sedation, and healing. In order to get a flail chest, you usually have to have a significant amount of trauma. So this isn't usually like their only injury. They usually have multiple other injuries as well. So a pneumothorax, remember, is just where you have, a hole either in the chest wall or hole in the lung, and some air gets into this potential space between the parietal and visceral pleura. It becomes a tension pneumothorax when so much pressure has built up in this space that it starts to cause a shift of one side or the other towards the mediastinum. So it actually is putting pressure on the mediastinum and it's collapsing the heart, right? And so now the heart can't fill normally, so the pressure's back up and we end up with that JVD. And because the mediastinum is shifting, you end up with a tracheal shift as well. You end up with absent breath sounds on the side that's affected. And then tachycardia, tachypnea, narrowing pulse pressure, and they look pretty horrible, right? So when they take a deep breath, this side is going to go up and down, and this side really isn't going to move much at all. The cure for this is a 20 gauge needle on kids and a 14 gauge needle on adults, about 2 inches long, at the level of the second or third intercostal space, mid-clavicular line, right there. Just going to pop it through. You may or may not hear a psh as the air escapes, and then this lung will reinflate. And that gives you a short fix. It might last 5 to 10 minutes. You'll notice if you're in the ER and somebody comes in like traumatic arrest, they might have multiple IV catheters sticking out of their chest, one or both sides. And that's because the pneumothorax may reoccur depending on where the hole is. Like if the hole is down here, it's going to keep reoccurring. So the cure for this, however, is a chest tube, right? 5th intercostal space, mid-axillary line, or 6th intercostal space, mid-axillary line, depending on the surgeon. Hemothorax is similar to a pneumothorax, except that the space is filled with blood. So here we see that space between the parietal and visceral pleura is full of blood, and it's collapsing the lung and putting pressure. You can develop a tension hemothorax as well, and you can have a hemopneumothorax, and the air will rise usually, to the top or separate out part here, and the blood will consolidate dependently or at the bottom. Wow, it's hard to color in a straight line on this tool. But eventually this will also cause a shift this way. Tracheal deviation, JVD, narrowing pulse pressures, tachycardia, tachypnea. And when they decompress the chest up here, the person will get minimally better, but not completely better, and they still won't develop any lung sounds where the blood is. And then when they put in the chest tube, there's going to be lots of blood. And that's okay. We're going to keep an eye on the H&H, right? And if the H&H is less than, we'll say like, 10 and 30, we're going to notify the doctor, and they're going to need to probably be transfused. Okay. So simple hemothorax is less than 1,000 milliliters, which would be a liter of fluid. Think about that. Think about your liter IV bag, all that blood sitting in the chest, and then a massive hemothorax is more than a liter. That's a ton.